All right, we're going to get started here. Welcome to the first session of the Topics in Geriatric Health Literacy Active Learning Series. My name is Tony Danuzzo, and I direct the East Texas Geriatric Education Center that is also in partnership with the East Texas Area Health Education Center's East Texas AHEC. Please let me know if you can't hear me. We don't have microphones, but the small enough area, I think, if we speak up, we'll be able to hear everything that's needed. I welcome you, and there's a lot of new faces, which is always good to see. And like I said, this is the first session of a series of 5 that I'll be describing on geriatric health literacy. And this first session is medical errors and ethics. Just some background that the East Texas Geriatric Education Center is funded by HRSA, and we're in our 3rd year. We'll be looking at a renewal this year, so we'll be looking for feedback on how we could even improve our programs in the next round of funding. We really target health practitioners and students in health professions to provide them with programs to enhance their knowledge and experience and training in geriatrics. And there's a lot of good reasons to be able to do that. This is a follow-up. We did a series of health literacy sessions that were more basics last year. And we have those recorded on DVD if you'd ever like to take a look at those. It'll provide a lot of good background information to what we'll be doing in the next subsequent 5 sessions. What we want to do is take what we did last year and apply it to even more advanced topics in health literacy for these next 5 sessions. We have an agenda. Today, after my introductions, I'll be introducing our speaker, Dr. Lee Grumbles, and looking at medical ethics. And that will be a lot of interactive role-playing. And so we'll have a chance to see issues of ethics and medical errors in practice. We'll also have some time at the end to fill out some evaluations, and there are lots of evaluation forms, a lot of paperwork out there that I'm going to explain briefly right now. Today we're going to be looking at addressing the needs of special populations, and we're going to look at two groups, those who have Alzheimer's and then older hospitalized patients. And in June, we're going to wrap up the whole series by trying to understand our medical care system, and this includes the financing, the difficulties in just maneuvering and navigating through this system. So I think these topics are applicable to everything that people do in this room, and I would appreciate any of your feedback and comments on what we have planned. Okay. Are there any questions so far about the program? All right, and in it is what you need to do. There is a credit request form for nursing credits. All right, it's 3 hours. And you just need to fill out and initial the sessions that you complete. That's on the bottom. Sign and fill in the second page. And again, there is a self-directed evaluation form for C&E. All right, separate from the CME evaluation. Okay. LVNs will receive a letter of attendance for their credit if they request that. We also offer CEU for PT and OT, and we do that through our general evaluation form. That's right here. Okay, and that's what we need to do for the PT. Again, sign in and fill out the general evaluation form. Are there any questions regarding getting your CE credits? Okay. One thing I want to make clear is the CME and social work are cumulative. In other words, you won't get your certificate at the end of this session. You'll receive them at the end of the June session, so after all 5, and those will be accumulated with the number of credits that you attend and that you request. CNE for nurses will be given after each session. Okay, they won't be cumulative. So you'll get, if you request CNE, you'll get a 3-hour certificate for this session after all the paperwork is handed in, and they generate the certificates, and they will be mailed to the address that you place on the form. Okay. And again, please remember to sign in, because that's what they need. For our purposes, for the GEC, we need to know who you are. We keep track of the demographics, your population that you serve in terms of minorities, those in rural communities, and those are important information that we need to report to our funding source, to HRSA. So for that purpose, there is this form. It's a participant profile form. Right. This is very important for us to receive one of these for being here today. You'll only need to complete one of these one time. All right, not for every session that you attend, for the 5 sessions. Okay, we'll have these on record, and then you'll be part of our system. And we'll be making sure you do this. All right. Okay. So, any questions? Everything okay? We're all good. All right, let's see if there's anything else that I had to do before I introduce things. Guess not. We're good to go. I'd like to introduce our first speaker, Lee Grumbles. She was born in Abilene, and she received her medical degree at UTMB in '97 and a residency program in internal medicine from '97 to 2000. Let me just move this back. Okay, she received an award for Primary Care Resident of the Year in 2000 and has been with the UTMB since 2001 and joined Geriatric Division of Medicine in 2005. She's Director of Palliative Medicine Program and Co-Medical Director of the Hospice Care Team. Dr. Grumbles has a board certificate in internal medicine and palliative care and sees patients at our geriatrics Galveston Clinic and local nurse facilities. She's extremely active in teaching residents, fellows, and medical students. I'd be really lost without her and her expertise in medicine and her experience and her devotion to education in geriatrics. I also would like to thank her because the speaker for this topic wasn't able to present, and so I approached Lee, and she was gracious enough to take on this extra presentation and saved me, to say the least. One other thing I want to do real quick is introduce you because we are also broadcasting. Right now we're broadcasting to Lamar University in Beaumont. Okay.
Okay. Well, I'd like to thank you all for coming today. I want to tell you a little bit about when Tony came in my office and asked me to do this. He came in and said, I've put together a PowerPoint. I want you to take a look at it. And so I kind of was going through the PowerPoint, and I knew when he came in, I was, in the back of my mind, I was saying, I sure hope Tony tells me he's going to present this, but I have a funny feeling he's going to ask me if I would present it. And so as Tony was diplomatically getting ready to spring the question on me, I had some things kind of running through my mind, and what I was running through my mind was, am I qualified to present this topic? And I got to thinking, you know, medical physicians are the one group of people that are really not qualified to present this topic. And why? Because we live in a culture that we were trained that we don't make mistakes. You know, it's the medication era. It's the transcription era. It is fate. But whatever, the physician, we were trained when we were in our residencies and our training that physicians make medical decisions. And regardless of whether they're the right or wrong decision, they're not considered usually an error. And so I started thinking back and I thought, well, you know, I've made plenty of errors as a physician. And over time, and I think it's time that physicians actually stand up as a physician champion for this topic and say, you know, it's totally fine to admit in our profession that we as physicians make medical errors. And so I decided, okay, I'm going to take this topic on. I'm not a content knowledge expert on this topic, but I think I have enough passion for what's right and wrong and ethically correct that I can be a physician champion to go through and to teach this topic. So first thing we want to do is, I want to read to you this statement from the Institute of Medicine from their publication, To Err is Human, Building a Safer Health System. The status quo is not acceptable and cannot be tolerated any longer. Despite the cost pressures, the liability constraints, resistance to change, and other seemingly insurmountable barriers, it is simply not acceptable for patients to be harmed by the same healthcare system that is supposed to offer healing and comfort. And I think we all as healthcare professionals have felt this statement. There's lots of things where we've gotten ourselves caught in situations where medical errors were made. And when we look back on it, we say, well, the reason was there wasn't enough money to put this or that into place. You know, the hospital policy said I could or couldn't do this in this manner. And all of those things seem insurmountable. Well, I believe in healthcare system overall is on a new horizon of change. And I think most people that are in the hospital-based system will agree with me, because quality assurance has moved from a bean counting science to an actual hardcore process and system analysis. And it's not something that some hospitals are doing. It is what you must do to get accreditation for your hospital and what you must do to get accreditation for your educational programs. So I do think culture is changing, where all of these insurmountable barriers are going to get started being broken down somewhat. Now, when you look at the definitions of errors, the most accepted definition that's put in the literature most often is from the Institute of Medicine, that document that I just read that paragraph from. And their definition says that an error, medical error, is the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. So for their definition, it's like we intend to do something, and the outcome of that intended action is not meeting the achieved aim. Now, in a few minutes, you're going to see, we're going to talk that there's lots of different things that fall, different types of medical errors that fall under that definition. Another definition by Dr. Leap out of Harvard University, he uses a second definition. He supports the Institute of Medicine as the first definition. But he has a second definition that he also says he thinks kind of helps include other things. And that's an unintended act which does not achieve its intended outcomes. So medical errors are not always something that is written or verbally ordered as a plan of care for a patient. Sometimes they're unintended actions that are carried out within the healthcare systems that have outcomes that are not achieving the aims for the patients. Okay. Now, impact of medical errors. Well, they can be devastating to patients. They can produce harm or even death. And they occur in all healthcare settings. When we look at medical errors, if we look at them, they're very hard to track. Because one, people have to feel the responsibility to report an error that they make in many times. And another, they have to be competent to recognize that they made an error. And lastly, they have to be ethically just to accept the fact that they personally could have made an error. When I told you that Tony walked in and asked me to give this lecture, and I was kind of, debating in my mind, I got to thinking, it wasn't only the training that I went through, but when I came out of medical school, I was pretty much put in the private practice arena and promoted to God. I worked with people who thought they could not commit errors. And even if an error was proven and brought up to them, they felt it was their responsibility to rationalize how they didn't make the error. So I think one of the important things to understand is that it occurs in all healthcare settings. And we have to be willing, regardless of the healthcare setting that we're involved in, to actually accept that error in ourselves personally and say we can make errors, and we did. When you look at statistics, there's a couple of studies out there. There's a study out of Utah and I think it's Utah and New York, and they looked to see kind of how many medical errors were made in a hospital setting. And what they found out is somewhere between 2 and 6%, depending on the actual setting. They can be very common. There's even another study that even says you can have up to 10% medical errors. That means in some situations, 1 out of every 10 patients that you interact with will have a medical error committed. Depending on the statistics on whether you want to use a 2 to 5 or a 10%, it works out that there's definitely at least 44,000 deaths a year that are attributable to medical error. That actually pushes the deaths from medical errors as the 8th leading cause of death in the United States, which means it exceeds the deaths caused by motor vehicle accidents. It exceeds the deaths caused by breast cancer, and it exceeds the deaths that were attributable to AIDS and HIV approximately 10 years ago. So we're talking a pretty big problem that we seem to constantly be shoving under the carpet and not accepting. And if we think about it a little bit, what we realize is that medical errors are especially harmful among those patients and those with low health literacy. And if we think, why are these people more likely to be impacted, more likely to be the ones who medical errors are perpetuated on? There's 3 accepted reasons for that. One is these people with low health literacy are more likely to rely on the expertise of their healthcare providers. They feel like their healthcare providers know more than they do about healthcare, and they need to trust these people and rely on what they're told. And as I just said, we as healthcare providers make frequent medical errors. So their trust has kind of been misplaced over the years. Another reason why this population is a little more at risk is they're less likely to do their own research on health illnesses. You know, it's difficult to find health care information written on a 5th grade education level. Think about when you go get a prescription filled at the pharmacy, and the pharmacist puts your medication in a little white bag, and he staples a printout to it and says, do you have any questions? If not, go home and read about your drug. Make sure you understand it. Has anybody sat down and read those pieces of paper that are stapled? They're not written where a 5th grader can understand them. Unfortunately, our HIPAA laws, or HIPAA regulation, says that it must be written in lay terminology that can be understood. And what is being done is people are looking at all of these informed consents, all of these patient education things. And what they're doing is they're saying, well, as long as it's being written at a level that a 9th grader can understand, we should be okay. Because when we look at the U.S., 85% of people in the United States graduate from high school and have a high school diploma or a GED. So we're making sure 85% of people are going to be able to be health literate enough to understand the information that we're providing to them. Well, what's happened is the people in adult education have actually studied what we write, and they've actually studied our patient population. And what they've found out is that reading literacy in the U.S. lags by 3 to 5 years. So if you graduate high school as a 12th grader with a high school education, on average, your reading literacy can be scored that you will read somewhere possibly at a junior high level. So when we look at the medical documents, the patient education documents that we give to our patients, and we score them, and I don't know anything about the scoring system, but there's all kinds of scoring systems that tells us at what level words, word structure, syntax is all being placed, at what level of education it should take to comprehend and read that. What we find out, most of ours are up at 12th grade. Good ones are around 9th grade. And we need to be targeting our communication probably around 5th grade so that we can assure that that 85% population is actually able to interpret the health communication that we're giving to them. Another reason, and I couldn't find where the documentation for this statement comes from, but I think it's probably true just from my gut feeling, is that this population of people are more likely to be trusting of their health providers. And I see that in my practice. I see my patients with the lower socioeconomic and the lower educational levels being more trusting in me to make decisions for them and assist the right direction in their health care. There is some literature out there that says certain cultures, certain ethnicities sometimes are less trusting of healthcare providers for different reasons, but I think as a whole, the overall population with low health literacy probably is very trusting of their doctors. I think a lot of them look at the physicians as the old-time physician where, you know, the physician cared deeply about them, knew them personally, knew their families. And I think they strive to have that type of relationship with a patient so that they feel good that they can trust their providers if they have that type of relationship. So those are kind of the reasons why we believe medical errors have a higher impact and are more harmful in the population that we're talking about over this next few months. Now the scope of the problem, well, there's non-medical errors and their medication errors. Everybody who works in healthcare professions knows about the medication errors. I mean, we all know what a MAR is, medication administration record, and we all know when a mistake happens anywhere in the process of delivering the MAR, you have to write up a occurrence report acknowledging there was a medication error. We know that it's tracked very closely by the hospitals so that they know that their medication error isn't trending upward. But I think it's important to realize that there's non-medical medication errors. And yes, definitely medication errors are the most common error that we admit to. But I'm not totally sure that it's truly the most common error that occurs. Some non-medication errors are things that result in injury. They could be preventable. They may have adverse effects on the patient and their health. They can be things as misdiagnosis. As a physician, I told you I've made multiple medical errors. The majority of my medical errors are in misdiagnosis. And misdiagnosis is a medical error. Not always an acknowledged medical error, but it is a medical error. There's equipment failure. We have patients, I can remember years ago as a respiratory therapist that I had a patient in the ICU on a ventilator, and all of a sudden my ventilator just went crazy. And the patient nearly died before I could even figure out what was going on and get the patient off the ventilator and get their ventilation, stabilized manually. So, we live in a high technology environment in healthcare, and we never know when one of our technological devices is going to fail on us, because they will at certain points in times. I I think the issue is to understand that whether we have non-medical errors or whether we have medication errors, they can be preventable. Okay? We may not get rid of all errors, but many can be prevented, and the majority are preventable if we had the right systems in place and processes in place to monitor for them. There's a big variety of errors. You know, we can have the extreme errors where, you know, the wrong leg is amputated. Here at UTMB, we have taken on the flight surgeons and the airlines system of there being a very careful checklist of patient, appropriate surgery, appropriate allergy review, appropriate surgical procedure that's fixing to get done, where the surgical procedure is supposed to get done. And it's a system where everyone is responsible, whether it be the surgery tech that's laying out the instruments or whether it be the surgeon that's fixing to perform the surgery. It is a full team checklist that everybody on that team in that OR suite must agree that everything is correct before they proceed on with the surgery. Once again, as I said, many, if not most, medical errors are preventable. We have prevented multiple medical errors here at UTMB by instituting this team approach in system prevention of medical errors. But you read on about it every 2 or 3 months in the newspaper at some hospital where a horrible surgery mishap has gone awry and the wrong surgery was performed or a wrong leg was amputated. You can have very simple errors that occur. These are the more common ones that occur. You know, the things like people who just were misreading or misunderstanding the label. This can actually be a problem that comes from the patient's end. You know, the patient receives a bottle of medication and then he has to read what medication it is, how many pills he's supposed to take, and what time of day he's supposed to take them. So misreading or misunderstanding the label could be a mistake by a healthcare professional, or it could be a medical error by the patient themselves. Then we have what I was mentioning a second ago, the diagnostic errors. The misdiagnosis on the part of the medical community. The wrongful ordering of an inappropriate or ineffective treatment or therapy for a diagnosis. Sometimes there's diagnostic test failures. We do the right diagnostic test, and sometimes the diagnostic tests give us the wrong answers. It's an innate statistical issue that we deal with in medicine. Not every test will respond appropriately on every patient. And sometimes there's misinterpretation of the diagnostic data that we get. We may get correct diagnostic data, but when we interpret it wrong. Thus, maybe misdiagnose, and or thus maybe give a wrong intervention or therapy. There's the equipment failure that I mentioned earlier and gave you an example of. And another simple and very common is nosocomial infections. When I gave you the statistic that 44,000 people died a year from medical error, that wasn't including the other 44,000 people who die from documented nosocomial infections. The rate of death from medical error, if you include nosocomial infections as a medical error, significantly skyrockets that occurrence rate. Now, communication errors can be misinterpretation of the instructions by the interpreter. So, I may be presenting information to someone and I may misinterpret what I'm being instructed to pass on to the patient. I find this, and we'll talk about this on a future lecture that we talk, when I have someone who speaks a language other than my language, many times I have to go through an interpreter to give the healthcare instructions. And there are many times that if I really delve into what actually got told to the patient, there sometimes are levels of medical error that do occur through just the interpretation from one language to the other language. Another thing with communication errors is that the orders are passed on by various health professionals. You know, a patient has to call the clinic office and tell a triage nurse what their problem is or what medication they need filled or what side effect they're having from a medication. And the triage nurse has to interpret that, hear it, interpret it, type it into a note. Then it goes to a physician's office staff who then reads that note and hopes to interpret it. And then that office staff may page the physician and over the phone try to describe to the physician what they read in that typed note. And then the physician then has to interpret and give some instruction back to the office staff. And then the office staff has to take that, and then they may call the pharmacy and order a new medication or a change in dosage. And then the pharmacist has to take that order from the office staff, type it onto a piece of paper, and put it on the bottle of pills. Look at all those levels. That's just your classic chain of events that occurs in medication error. And at any one of those links in that chain, any small miscommunication can cause a devastating problem for the patient with a medication error. No one meaning to cause an error, just the innate nature that it goes through so many levels of communication that we can cause errors in what we thought we heard or what we thought we read or what we thought we understood. We refer to that a lot of time in communication as the telephone effect. Everyone, when they were children, played that game in school where the teacher says a sentence to the first child and then that child hears what they think the teacher said and tells the next child, and the next child passes it on. And when it comes all the way back around to the room and they announce to the teacher what she said, it's never a correct statement. So every person or every link in the chain puts a higher risk at a mistake and a higher risk for a large error to occur. We also talk about a chain of responsibility, and it always starts with a health professional. It could be the physician or the nurse who actually is teaching or giving the orders to the patient. It could also be the other providers, such as the pharmacist who fills the prescriptions, a hospice worker who takes a verbal order or interprets a protocol to instigate a certain healthcare order. But regardless of who is being the primary health professional that starts that chain of responsibility, the communication is going to fall on a family member, a patient advocate, or the patients themselves. So we cannot get away from the chain of responsibility. It's just very rarely going to be truly physician to patient. That's very rarely the communication of medical information. There's nearly always at least one third party involved between the physician and the patient themselves. And if we talk about it, we're saying we as healthcare professionals have a major problem of medical errors due to this telephone effect. Well, think if we are health literate and we're having problems with medical errors, what will happen when we're trying to communicate medical information to a family member, to a patient advocate, to the patient themselves? And they don't have the level of health literacy that we have. We're compounding the issue and the probability of medical errors to occur in that communication. So I've given you a lot of information and a lot of background, but let's talk about some of the challenges, some of the pragmatic things. You know, we know it happens. We know it happens a lot, but pragmatically, what's happening that we might have some control over? Well, some of the challenges is language. You know, the medical lingo, catching ourselves using unfamiliar terms with our patients or with our family members or patient advocates. We need to be very, very careful to listen to ourselves and make sure that we cut out the medical lingo and talk to our patients on that 5th grade education level. Now, I'm not saying talk down to them as if they're an immature child. I'm saying use word choice in an adult tone with your patients at choosing words and terminology that you feel like a 5th grader could understand. It's not condescending. It is purposeful word choice. Okay? Another thing is realize and recognize language barrier by culture. And language barrier doesn't always mean that someone speaks a different language than you. Sometimes we have culture where people just believe medicine from the conventional way we practice medicine isn't exactly the same as their definition of medicine. So when we start trying to communicate, even if we do it on a 5th grade communication, and we are communicating it, we have to realize, is their culture allowing them to interpret what we're saying, or is their culture interpreting it differently? Sometimes it's not the words we choose, but sometimes it's the way that we're using them or the situation that we're using them. So we have to be very aware not only of language barriers, but also culture barriers that are causing problems when we give these instructions. Something that I know most people sitting here are very interested in geriatrics, and we are always worried about the hearing and the vision. I am a person that repeats over and over my instructions to the patients. And my patients many times probably think it's condescending, but my concern is that when it's important to me and I want to make sure that it gets done, I feel like if I reiterate several times in my conversation what instructions I want them to get, one, they'll understand the importance of that instruction I'm giving them, personally that I feel like it's important for their health care, and 2, it'll be given enough times that there is no error, that the patient will definitely get what I said and understand it. There's lots of people that they print or type all of their instructions out to their patients and they hand them a piece of paper with written instructions when they leave the office. Everybody has different techniques in how they try to overcome this problem and this challenge. And there's really no proof on what works. It seems to be what works for your personal communication style, not that one technique is better than the other. Another challenge, and I think we all as healthcare professionals have had this, is the product packaging inserts for prescriptions is based off the physician's desk reference. So, 1, it's not written for the lay, definitely not written at a 5th grade education level, and it's written with information that culturally, without a healthcare background, cannot be interpreted. And so one of our challenges are our patients who try to be health literate go to these product packaging inserts to try to gain their health literacy. And it many times causes more problems and more confusion than it actually does to resolve any of their questions and issues. So then we come to the readability. Well, there's barriers for patients in obtaining their health-related disclosures. One we've already mentioned, and that's the Health Insurance Portability and Accounting Act, HIPAA, which says we have to give this to patients in lay terms that the average patient can understand. The issue is that HIPAA did not give us any guidance to actually say what we should do. I didn't bring it, but I actually have some samples of some informed consents. One of the informed consents was for a surgery, and when you went to one of the paragraphs, you counted 160 words in one sentence. Now, I don't know about you. You know, I got MD after my name, and I can't interpret 160 words. There are too many commas and too many semicolons for me to even begin to figure out the grammar and structure of a sentence that contains, one sentence that contains 160 words. And our informed consents are one of the things that HIPAA says we must write in a manner that our patients can understand. So I think if we look at the issue, we as a healthcare system are failing our patients royally in giving them something that a layperson can understand. Another thing is we're so worried about a litigious society that everything we write is written in legalese. You know, we're more concerned about whether it's going to pass our lawyer or our legal department. And so everything we write for a patient, any type of instructions, any type of communication, it's all ran through legal. And then once legal puts their slant on what they think is going to protect us as healthcare providers, it increases the difficulty in reading and interpretation. So all of these problems are coming together to make what we're trying to do as a benefit to the patient actually creating as a barrier. Then we know that there's always problems with medication confusion. You know, there is absolutely no simple medication instruction. If you tell a patient, I want you to take one pill of this once a day, it's going to be, okay, do you want me to take it in the morning or in the evening? Do you want me to take it before or after a meal? Can I drink milk when I take this pill? I mean, there's no simple medication instructions. Everything is very complicated. So one of the things that the American Healthcare Quality and Research has put out is what's called the 20 tips for patients, and I think Tony may have had that as one of our handouts. It's a very good resource. If you go to their website, you can pull up this one page and you give it to your patients, and it's got all these tips about what a patient should ask their doctor when they're given a medication prescription, so that they know, you know what it is you need to clear up with communication to our patients, and the patients know what to expect the healthcare providers to make sure that they've cleared up for them. Another thing is a medication diary. We'll look at one of the diaries in a second. A medication organizer, and I'll show you an example of one of those in a second. And finally, they want us to utilize more electronic prescribing rather than written prescriptions. We have proven that by going with electronic prescribing, the error in handwriting significantly reduces the frequency of pharmacists and nursing and other healthcare professionals misinterpreting what the physician actually was intending the medication or the medical intervention to be. So, and here at UTMB, we actually have electronic medical record, and I haven't seen the studies, but we actually are looking at studies from, I think it was 1996, and then I think was in the process of doing the study with 2008 when Hurricane Ike came through, and I'm sure it was suspended at that time. But it's looking at taking several of the departments and looking at what was their documented medical error rate before and after we went to electronic prescribing. So hopefully we'll have that quality assurance information here at UTMB in the next year. I know for sure we've improved our medication error rate by doing that. Now, just to show you some examples, this is an example you have in your handout of a personal medication diary. There's numerous diaries out there. Some of them are just listings that patients and you fill out so the patient knows what their medicine is, you know, what the generic name and brand name are of it, so there's not confusion in ordering. You know, what they're taking it for. It's very important for them to understand the reason, the diagnosis, the symptom that they're taking their medication, what time of day they take it, any side effects that they need to be looking for. Some diaries even go to the extent of having monthly login charts where the patient actually can check off that they took their medications. And as they complete a medication administration, in their diary they actually check off that that medication was taken. So you can actually take the diaries, review them, and see what percentage of compliance your patients are achieving. Then there's what's called a personal medical organizer. And personal medical organizers kind of take the concept of the medical diary and they expand a little bit. They give the patient an area to document what medical problems do they have, who are their doctors, and how do their contact for their doctors, you know, who is their pharmacy and where do they use and what contact numbers do they use for their pharmacies, as well as their medication listing. So a personal medical organizer is very, very good for geriatric patients. I can remember back in the 1970s, we used to ask our geriatric patients to go get a pill bottle, an empty large pill bottle, and lots of clinics and hospitals would give them a personal medical organizer so that if the patient ever had a problem and the EMS showed up at the home, they would go to the refrigerator, pull out the pill bottle, take out the piece of paper that had doctors' contact information, hospital contact information, allergy information, most current listing of medications. We started doing that and with some success in the years, but the problem is you have to have a family member or a patient that's going to keep that information updated. And as occurrences occurred where the information was interpreted inappropriately because the information was not updated, kind of fell out of vogue, and it's not something that's done, but that's where the personal medical organizer originated from, was in the 70s with that concept of keeping your medicine information in a bottle in the refrigerator so the EMS could find it in an emergency. Now we'll talk about some tips to help patients remember to take medications, and this is just a listing. I have them listed on the next slides with some kind of visual cues so we can kind of go through them one by one. One is pragmatically place large labels on pill bottles or use some color code for the patient so they know what they're taking, why they're taking it. I'm very impressed with Target. Target, with their new packaging, uses wonderful large bold print that is so easy to read. It's just been becoming wonderful. The other thing is, as a physician, I just hate trying to read through every word to try to figure out where the refill number is, who the physician is, where the phone number. And Target has just taken that and made one line for each one of the pertinent information and just made it very user-friendly for the healthcare providers as well as for the patients. So different companies, I'm sure more than Target's done that.
And you're not affiliated with Target. This
Yeah.
is an example.
Okay. I just didn't want to get you in trouble there. Yeah. I'm sure other pharmacies have other ways of doing it, but I like Target, so I put Target's up there because I just think I can read it. You know, I have progressive lenses now, so I am beginning to understand why my patients have trouble reading their pill bottles, because lots of the time I have trouble reading my pill bottles. The other thing is this color code system. I use this all the time. Not this specific brand, but you can search on the internet and you can order these very inexpensively for your patients. And what I do is I take a pill bottle and I put a different color little dot on it, and the patient knows what time of day they're supposed to take their medicines. Even if they can't read what the medicine, what it says on the prescription, typed on the prescription, they know that a yellow dot means to take it at this time of day. A green triangle means to take it at another time of day. So color coding and shape coding really helps people with low health literacy manage a complicated medical regimen. Another thing we do is get people to buy, and I say and use, a pill box. Now that I'm a hospice and palliative medicine physician, I do most of my healthcare visits in patients' homes. I do the home visits. And one of the things is I say, let's see where you keep all your medicines. Let me go through your medicines. And notoriously what I find is there's a shoe box full of pills. And yes, there is a pill box there, a plastic pill box, but they don't use it. Some doctor or healthcare professional at some point in time told them they needed to get a pill box and start using a pill box, or maybe even a family member encouraged it. They purchased the pill box, but then there's an obstacle that keeps them from using it, whether it be that they don't feel comfortable or competent to fill it, and they need to have a healthcare provider or a family or an advocate fill it for them. Or sometimes it's just the psychological aspect of, if I have to use a pill box to keep up with my medicine, that means I'm getting slow. I must be getting dementia, and I'm not going to do that. And I find lots of elderly people that would do much better with a pill box, but they refrain from using the pill box because of the stigma that comes along with transitioning into controlling medication and administration with pill boxes. So I say not just buy it, but we need to encourage our patients to use it. Another thing we do is we set up a routine, specific place to take medicines. You know, this may be in the bathrooms. It may be at the kitchen table. It may be in the living room, sitting next to the easy chair in front of the TV. But there needs to be a very routine place where the patient will be triggered that when I'm at this place, my medications are here, and they will be a visual trigger to think of taking that medication. That's different for different people. I've had some people, it seems the most successful place that I in home visits have found is the kitchen table, right there with the salt and pepper. You know, I keep the pill box right there with the salt and pepper, and it seems to be that is enough of a cue. I think people are going to naturally sit at a table and naturally go for their salt and pepper, and so they're going to think about taking their medicines and know that it's part of their everyday life. Another is posting reminders in visible locations. A lot of our Alzheimer's patients, family members, and healthcare providers who service in the home do this a lot. They'll make little notes and post it on the refrigerator or on the mirror in the bathroom to try to cue the patient that they need to think about taking their medications. And so lots of times I walk into home, and I walked in the home one time and there was like little different color post-it notes all over the place. And I don't know how the little lady ever kept up with anything, because the post-it notes weren't just to take care of the medication. It was her family trying to remind her to brush her teeth, trying to remind her to take the trash out on Tuesdays. You know, I couldn't have processed through all of the little colored stickies that she had throughout her house. But the concept was there. The family was trying to give her a visual written cue to help remind her to do things. I think we just have to realize that sometimes in excess, the visual cues will do the opposite of cueing. They'll become as if they're not there at all. So we have to kind of prioritize what we make the visual cues for. Another thing is making sure that there's a readable clock. If we tell someone we want them to take a medicine at 8 o'clock in the morning, right before they eat breakfast, they need to have a clock that they can see and that they can read. And so not only do we need to have our medications labeled in a manner that the patient can read, but the clocks that we're using them to time the administration of their medicines need to be visible and readable. Once again, right next to the salt and pepper shakers and the pill box, I have them put a large lettered clock so that it helps my homebound patients be able to keep up with what time of day it is and when they're supposed to take their medications. Something else that's used, this is a concept that I use for people with just mild dementia or just people who just don't keep up with what's going on. And that's, I take a 8x10 piece of paper with this large clock on it, and I take the color coding system, and instead of just color coding the bottles, I actually color code the clock as to what color bottle they go to. So if they take a medicine at 8, 12, and 4, I might, have a yellow, a green, and a blue tab on it. And at the times that they're supposed to take those colors, I will have a yellow, a green, and a blue tab on the face of the clock. Once again, that piece of paper sits right next to the clock, right next to the pill box, right next to the salt and pepper, right there on the table, so that we have a system, a routine system that they get used to working with. Another problem that we who work in geriatrics know is a problem is thinking ahead, getting our patients to think ahead 3 to 5 days so that they will call and ask for a refill, and there'll be time to get the refill done and time for the pharmacist to refill it. Notoriously, older people will call the day they take their last pill. And so we need to really educate and try to help our patients realize that when they're running out of their prescriptions, they need to give a little timing. The way I try to help as a healthcare professional with that is I try to get all of my prescription refills synchronized so that people are not having to go every week to the pharmacy for a 30-day prescription to run through. So they go to the pharmacy once a month. And then what I do is try to get them to put on a calendar a big circle around the day that's 5 days prior to that medication refill actually running out. So they know on that day they call the pharmacist and say, I'm fixing to run out of my medications. I need you to refill everything so I can get in the next 5 days to refill it. This has been the most problematic thing with compliance. I really struggle trying to get my geriatric patients to refill prescriptions. The other thing I struggle with is I struggle with the healthcare system trying to reconcile and get all the prescriptions filled on the same date. If I go through and look at the prescription bottles of my patients, if they have 10 bottles, lots of times there's 10 different refill dates when they're going to run out of their medications. And it's very confusing for an elder person to try to keep up with that. So our system that we use with the pharmacies really kind of impairs our older people to be able to keep their medicines refilled in a timely manner. To kind of sum it up, there's just a few other tips and solutions. Beyond what the Institute of Medicine, Quality of Healthcare in America Committee said, which is we need to start looking at and forming ways to make sure that we aggressively try to reduce medical errors, we need to just use some standardized guidelines when we're trying to meet the needs of our low health literacy patients. Remember, communicate instructions on a 5th grade education level. Be careful with your word choice. Be careful with your sentence structure. Use fewer words, more illustrations, and more visual aids, if at all possible. Make sure that you're using larger print, and make the use of color coordination if that's a system that works for your patients. And employ, which I currently is the main thing that I use, is a talkback method. Anytime I ask a patient 2 or 3 times, I tell a patient 2 or 3 times my instruction, I always want to make sure that that instruction is told back to me so I know they understood what I said. So you use a talkback method to ensure that they understood the instructions that they were given. Now what I want to do to close this portion of the lecture out is I want us to break up in small groups. And doesn't really make any difference what size of groups we have. We've got a big group here at UTMB, so we ought to be able to make about 6 groups out of this group. We're going to be a little more challenged at Lamar. It's going to be a smaller group. But let's everybody get together at Lamar. And what we're going to do is we're going to do 2 exercises. Yes, Dr. Vogelpool? Yeah, I knew Patty and I were going to say the 2nd grade. I knew you and I were going to go there. Patty's an occupational therapist, and so occupational therapists are taught to communicate on a second grade and then work up. So I knew Patty was going to say second grade. Most people, when they're given these, do say that they feel more comfortable communicating to the person with the higher degree of education. Now let me ask you a question. When you were practicing and talking about what you were going to say with this first scenario, do you think you presented and chose words on a 5th grade education level?
Initially I did because she asked me what was compliance. She was different. You were making a difference.
Exactly.
Sometimes you do.
That's true.
Exactly. The word compliance is not a word that most 5th graders, you can assure, would have an understanding of that definition of that word. So merely the choice of communication that I asked you made an obstacle on you to have to stop and think about what would a 5th grade understand in conversation. So the whole purpose was just to let you stop and think about your words. And what we must learn to do is when we're talking with our patients, we must learn to have some thought process going on where we're kind of thinking on our feet. We're trying to think, okay, I need to tell them this. How am I going to express this at a 5th grade word choice level in sentence structure? One of the things that I've found that has really helped me is I learned to talk slower. Those of you who have known me over my career know in 2001 when I came to UTMB in my first lecture, you couldn't have kept up with me. I just talked so fast and just went on and on and on and on and on and on and got more excited. And what has helped me more than anything with my teaching, as well as with my patient-physician communication, is learning to slow down and learning that silence is not bad. We always feel like we have to feel every moment that there can't be silence. We have to be speaking and talking. But the issue is if you learn to feel comfortable with little breaks of silence, it gives you that time to process that word choice and that sentence structure. And what I found is my patients don't think I'm stupid and can't think what to say next. They think I'm being insightful by slowing down and taking some time for them and I to both think and self-reflect. So learning to slow down and use purposeful small pauses while you think of your word choice will help you a lot in carrying this out on a day-by-day process with your patients. Now, let's open it up. Does anyone have any questions or anything they would like to share with the group? I know we've heard from Dr. Rakovich and Dr. Vogelpool. Does anyone else have anything they would like to share?
Go ahead.
What about Lamar? Does Lamar have anything they'd like to share with us? Okay.
Yes.
Yes, Lamar?
Yes. Well, I was Patricia Lewis, Logan. I was confused about the buying of medications for the whole month. If you're not able to buy 10 prescriptions or maybe even 5 prescriptions, I would see it as a problem for a senior citizen on fixed income.
Yes, I've had that problem happen times before where we've had to stagger prescriptions because of financial issues. And it's not a concept or system that I found works for everybody, but there are certain patients that I seem to be able to consolidate that and make it useful. The other thing is if I have to break out prescriptions and stagger a couple or 2 or 3 refills over the month, I try to make sure it's the same medications over and over again so the patient very understands that, well, when they refill their Plavix, they always have to refill their lisinopril at the same time. But yes, that's a very good point.
I was going to say, sometimes you're confronted with people, especially the ones who say Plavix, they've gone and researched stuff, they hear the TV information, and they try to tell you those kinds of things, and it kind of makes it difficult, like she was making it difficult for me just to you know, and I normally probably face a scenario presenting with too much stuff. Like, I'm going to take this pill 4 times a day in order to comply with how it's supposed to work. And that was my first confrontation, was what is compliance? And I found myself saying too many words, but I think normally I'm looking at them. Of course, I don't deal with medicines, but, you know, sometimes I found with her, just saying too many words made it more difficult to just be simple with it.
So what you've proven to yourself, what I was just talking about, is the more words we put into a sentence structure, the more difficult it is for the patient to comprehend the meaning of what we're trying to express. Great, that exercise got across exactly what I was hoping it would. That is wonderful. Very, very good.
And one thing to reiterate is that, especially in professional places, whether it be business or education or medicine, when we see that term, a business degree, second grade education, that has nothing to do with their level of understanding. And so a person with an associate's degree may not have the level. As you said, there's a difference between their understanding level and then that year that we put on it. So 5th grade level, you may have a high school senior that reads at 5th grade level. You may have a second year education who reads at 5th grade level. And we get all kinds of preconceived notions as soon as we see that magic identifier.
Exactly. And I think building on what you said that is really important is that we make assumptions about patients. We make assumptions about somebody who works in healthcare, that they automatically understand stuff when they don't necessarily have the background or applications in healthcare that they would understand it. We say, well, what do you do? Well, I work at UTMB, and then you're like, oh, so you get all this. And the answer is, no, I don't. And even, as a physician, when you're in an area that's not familiar to you, and the physician you're seeing is saying, well, and then just do this, and you get it's like, then you're kind of like, well, I don't want to tell them I don't get it, so I'll go home and read about it and figure it out on my own. But there's a natural assumption if someone says something, you'll understand it. And I think the talk back, could you just take a second and repeat to me, now, what did you understand about this? You can do it in a clip note version, but I think it's a very useful technique, regardless of who the patient is.
Okay, we're going to do some communication and medical ethics. And I have a co-presenter for this section, and it's Dr. Karen Zotter. Dr. Zotter has been my mentor for the past few years. She does a lot of educational research here at UTMB and is nationally known with her medical research, and also nationally known with having one of the leading standardized patient programs in the United States. So I really appreciate Dr. Zotter helping me today with this. So we'll get started. We have 3 objectives today for this section. One is we're going to describe the characteristics of a positive safety culture. Some of y'all may have heard the term positive safety culture and some haven't, but we're going to define it. Second thing is we're going to practice through role play how you would disclose a medical error to the healthcare team and to a patient. And lastly, we're actually going to view a role play of an interprofessional team performing a medical error disclosure. So let's talk a little bit about the definition of a safety culture. An enduring shared belief and behaviors that reflect an organization's willingness to learn from their errors. A culture that sees medical error as positive is a culture that recognizes their errors and uses those errors to improve their environment, their product, their outcomes. And there's 3 basic beliefs that's always present in a safe and informed safety culture. One is that all of the processes that you have are designed to prevent failure. When you decide you're going to start something, you think about where it could fall apart and where you could have points of failure within that process and that system. And you try to, with forethought, design a system that protects against those weak links where failure might occur. Another belief that has to be present in a safety culture is that we have to be committed to detect and learn from our errors. Instead of feeling threatened that we made an error and feeling uncomfortable admitting our error to our colleagues or to our superiors, we need to see it as beneficial, something that is going to help us change our process and systems so that error does not occur to someone else again in the future. It protects you from ever making the error again, but it protects your colleague from making the same mistake that you made. And lastly, one of the beliefs that must be in a safety culture is that we have a just culture that disciplines are based on risk. I'll give an example of this. Recently, I had a nurse at one of my nursing homes who was fired because she had a little elderly lady that had some soft, mushy heels. And she sat at the patient's bedside and rubbed them with lotion over a weekend when she had a little free time because she loved the little lady and loved to talk with her. So she sat and rubbed her feet compassionately and caring and caused a stage 2 decubitus to pop up from her heels. The nursing home administrator, as far as I was concerned, significantly overreacted and fired the nurse for the medical error. Just because a medical error is made doesn't mean that all medical errors are something that are punishable. And in a safety culture, what we understand is that different errors have different outcomes and they're risk stratified. Now, I'm not saying that all medical errors are acceptable and you won't get fired for a medical error. There are certain medical errors that are negligence and are malpractice. And there is a chance that you might be relieved of a job because of a medical error. But in a safety culture, you're not fearful of the normal run-of-the-mill errors that you cause because you know those errors are being looked at as a lower risk and they're being looked at and trended so that processes and systems can be changed to prevent you and your colleagues from future error. So a safety culture is really a nice place to work. What are some of the components of safety culture? Well, one, you have to have open reporting. Staff have to report their errors. They have to feel that they have a responsibility to acknowledge their errors. And they have to understand that they have a responsibility to start looking to recognize their own personal errors. They also must feel comfortable, and they must feel comfortable with others reporting errors. So it's not just reporting your own personal error, but it's if you recognize someone else with an error and that person didn't recognize their error, you need to feel comfortable reporting the error. And the person committing the error must feel comfortable with their colleagues recognizing and reporting the error. Now, I just did what I told y'all not to use. I probably used 160 words in that last sentence, but I couldn't figure out any other way not to do it. Another thing within a safety culture is a safety culture must be just. Reporting is rewarded in a way. Reporting errors is that you're caring about the outcome and the product of your healthcare system. And that you are reporting not because you're trying to get someone in trouble, but because you are concerned with the quality of the product that you're providing. The other thing is that in a safety culture, there's always a very clear line between acceptable and unacceptable behavior. Now, I happen to think that's pretty much in any part of the world that we live. I think we all have an internal conscience that tells us what is acceptable and unacceptable. And I think we should be very clear to ourselves and our colleagues what we consider as unacceptable behavior. One of the things in a safety culture is that disruptive behavior is not tolerated. So physicians who throw surgical instruments across a surgical field are disruptive behaviors, and it's not tolerated. Nurses who might not clean up a mess because they don't like the nurse working in front of them, and they're thinking, well, if I leave this alone, the supervisor is going to find that the nurse in front of me didn't do her job like she was supposed to, and she's going to get in trouble. Unacceptable disruptive behavior. In a safety culture, we know what is acceptable and unacceptable, and we do not allow unacceptable behaviors. Another component of a safety culture is that they have to have flexibility. You have to be very flexible. The authority and the supervision within the safety culture, their patterns will flex. They will relax and stiffen depending on what information is exchanged. So you're not going to fire someone for reporting a problem when it's not a big, huge risk issue. You may have a policy that says that's not to be done, but when it's reported as a problem or as a medical error, you flex that because the issue is you want to recognize that medical error and then work on the system or the process so that that error doesn't occur anymore. Make the system where the error is foolproof, where it can't come back to haunt you. Another thing in the safety culture is it has to be a culture of learning. Every action is based on safety information systems. Every time we find an error, we analyze the system and the process. We look for the weak links. We look for ways to improve the weak links so that they can't break and the system can't break down and can't produce an error. And we learn from that. Everything we're doing is a learning process trying to ensure that we make a foolproof culture that tries to alleviate by system processes as many errors as we can. Now, what are important steps in self-reporting a medical error? Well, one, if you're in a safety culture, you feel very comfortable with it. Okay? And one of the things you're going to do is you're going to avoid counterproductive responses to errors. Okay? When you make an error, you report it as objectively what happened. You don't try to be counterproductive saying, well, it's the hospital's fault because the policy said this. Or it is the occupational therapist's fault because she didn't put the side rail up. You stay away from counterproductive responses. Another thing that you do is you accept responsibility for the error. If you committed the error, you acknowledge that you committed the error. A third thing is you disclose the error to both the healthcare team and the patient, even if the error did not have a negative outcome. All errors must be disclosed to the patients. And lastly, you want to use your lay language, as we've talked about in the previous lecture, 5th grade level, when you communicate and disclose that error to the patient. So what we're going to do today is we're going to do a role play of an interprofessional team performing a disclosure. And it's going to pretty much mimic an interprofessional team that we would have here at UTMB. So what I would like to do now is ask Dr. Karen Zotter to come up, and she's going to take over and read the case to you that we're going to role play today, and then facilitate some discussions about the role play.
Okay, so what we're going to do is we're going to set the stage right now so that you understand what this team is actually going to be talking about. And as we go step by step through this case, what I'd like you to do is look for spots along the way where you think things went astray, and the beauty of reading this or reflecting on it is you can stop and think, maybe if we had made a different decision point here, things would have happened very differently, okay? Because that becomes very important, because what we have is what we have, and the outcome is where it is. But part of what Dr. Grumbles was talking about is sort of deconstructing and working backwards and thinking, identifying the hot points along the way where different decision points could have been made that possibly could have prevented a less preferable outcome for the situation. So we'll begin by describing it. Rafael Mendoza is a 24-year-old Mexican national who's been working on the Galveston port for 2 years with a legal work visa. He's been promoted twice at the port. He makes a good wage for a single man. He's entered Galveston Community College and is working towards a certificate in drafting. 1 week ago, Rafael's mother and father made a trip to visit him from his hometown in Mexico. He was surprised when he realized his parents had brought along his bedridden grandmother, who was aphasic and required assistance with all activities of daily living. When Rafael's parents left 3 days ago, they refused to take his grandmother home to Mexico. They insisted that he must grow up and take on his responsibility, telling him he was making good money here in the U.S. and he could better take care of his grandmother than they could. Unable to care for his debilitated grandmother and work, he called the EMS and brought her to the emergency room. Upon arrival to the emergency room, Rafael told the emergency room attending that his grandmother had a change in condition overnight from walking, eating, and talking to being aphasic and bedridden. The emergency room attendant admitted the patient to UTMB under the diagnosis of an altered mental status. The admitting intern now talks at length with Rafael, and the truth of how he had become his grandmother's care provider and the truth that her current condition was her baseline function now came out. The intern documented in his note that the admission was for social issues and needs placement. He told Rafael not to worry and that he felt they could get his grandmother into a nursing home. Diagnosis of social issues did not meet criteria for hospital admission, so a social work consult was called in the next morning. After social work documented that the grandmother was an undocumented alien and the attending documented that the patient had no acute medical problems, an interprofessional team meeting was called to discuss the plan of care with Rafael. So, we're going to debrief now. Okay, so I want you just to reflect back on that scenario and think for a moment, and we're going to do this just in buzz groups just for a minute, so just look at the person next to you and identify at least one place in this continuum of process where medical errors were made, and sort of some of the ethical foundations, or even some of the, if I was there, I probably would have done the same thing, done a different thing. And also think about how health literacy will affect the communications that the team now has to have with the primary care provider, that is the grandson Rafael. So if you can just turn to the person next to you and just take, like, how much, 4 or 5 minutes? And think about where along the way did you see something go awry, and what could have been done differently that potentially would have prevented this spiraling and ending up where it did. Our main star of the show, who's a young man who's in town, working hard, doing well, and establishing himself in Galveston with a good income and moving ahead with his education here locally. His parents come to visit and bring along his grandmother, who is clearly chronically ill, and requires excessive one-on-one care for optimal survival. His parents leave and they say, we're not going to take her home with us because you have better resources and better opportunities to provide for her. Stop me anytime. Is there a health literacy problem right there?
Yeah, but part of it, the way I understood it, it was things that we could do. There's nothing that we could have done to do any of this. That's all.
It's cultural.
It's cultural, yes.
Yeah. But health literacy, is there anything, because one of the second questions was, what kind of things when we communicate with Raphael do we need to get from this? Is there anything health literacy-wise that you think we need to think about?
He's only been here 2 years. So what are his language capabilities? Has he had English interaction, the socioeconomic status of other dock workers, and maybe have been no?
Right. And what else? What's another health literacy issue, maybe with the fact that he grew up in Mexico and has only been here 2 years?
He's trusted in the profession.
Right, he does.
Curanderos are leaders.
Exactly. He's been from a total different healthcare system. Our healthcare system is totally alien to him. So what we take that people naturally understand as U.S. healthcare, Raphael may have no understanding at all of how our healthcare system works here in the United States. Exactly.
Okay. So we're now at the situation where his parents are gone and Raphael has his grandmother, the responsibility for his grandmother, and recognizing that he can't work to be productive, to provide what she potentially could need financially, he decides the safest thing to do would be call EMS and take her to the ER.
I think there's another health literacy problem right there because he probably doesn't know what she needs. So even if he had the time, what is he going to do? Does he know how she needs to be fed? Does he know how she needs to be, what medication she's on? Does she know anything about her care that he could potentially do?
My question would be EMS taking her anyway, as far as what is he telling you the criteria for them picking her up to say she needed to go to the ER?
Okay, so the question of why was EMS willing to transport her to an emergency room, and how was the situation presented to them? And also the question would be, was there a way that he would know that certain criteria would absolutely make her have to be transported versus others? Because those are sort of the TV drama things that we see, honestly. You know, so he may have had preconceived notions about why EMS would take her, where they would take her, and what would happen once she got to the emergency room. Okay. Now, he's in the emergency room, and he tells the ER physician that yesterday she was walking, eating, and talking, and today she is aphasic and bedridden. And the attending physician admits the patient for altered mental status. Any thoughts on where we are here?
He discussed that, and it's easy to analyze it in retrospectively. You're not the physician in the ER, but there must have been other clues that suggested that this was not an acute event and that there was something wrong going on.
So,
And the language barrier, he may not have told that to the physician, or the physician would not have understood exactly what Raphael was telling him. That's part of the history.
so something to the effect of she used to be up and around and walking and talking, and now she's here, and this is interpreted as an acute alteration rather than a chronic change.
But I sense a sense that because he's been in the U.S. 2 years, that means that he's not fluent in English, which might not be the case.
Correct.
He might be bilingual and coming to the U.S. from Mexico and only being here 2 years, but still be fluent and able to communicate. So both are assumptions, but...
Right. Go ahead.
Why can't we look at it from another perspective? He's been here 2 years, he's in school, you know. He might know the system enough, he knew what to say.
Correct.
So he knew the key words
Correct.
to say. Because if you don't know to say that he would have said something. And so in essence, he didn't tell the truth.
Right. So there could be,
Those were the buzzwords that he knew to say to get her in the door and someone to look at her.
and those could be intentional or non-intentional, but with the idea of this would be best for her. So it may have malicious or non-malicious sort of underlying tones, regardless, however you want to frame it. Tony.
And with the our tenant be talking to the EMS, that is as part of her being brought in, or not?
Sometimes not.
That, so they would just rely on Raphael's observations rather than EMS reports or anything?
The EMS check out to the nursing staff.
Typically check out to the nurses. And Dr. Vogel?
Two comments. One, it's the dump syndrome, and two, about the only practical way around is hospice as the least costly solution.
Okay. And that may be projecting out where we may choose to go. So in the acute moment, though, again, we can't second guess intention. We can't second guess anything other than him saying, in the current situation with grandmother fully in my charge, I can't provide for her in the house, so I need to do something, and this is a quick way to get her into the medical system, right or wrong, whatever the intent is underlying, we have no idea. Okay, now the admitting intern meets with Raphael, and they speak for quite a while, and now it comes out that now the truth of the situation, that his parents left her behind, and that this was her baseline function at the time that his parents left to return to their hometown. So the intern documents in his note that the admission is for social issues and needs placement, telling Raphael not to worry, that he thinks he can get his grandmother into a nursing home. Okay, where are we going with this series of events? Okay, so does the intern document social issues out of naivete? Doesn't realize that that is not a legitimate documentation reason? Or does he do it because he or she understands that that will get a whole different process going for the patient? We don't know. We don't know what the intention is here. We do know. Absolutely. We do know that it generates a social work consult. Go ahead.
Care management, when we get these particular issues, we know that we don't have much time, because we know that that's not a reason to be in the hospital. And so we start investigating. We work with financial screeners and admitting to make sure there was not maybe a husband who had worked in the U.S. and had Medicare, make sure he had it. So we go through a whole ball of issues that we're looking at, and then once we determine, oh no, she's undocumented based on our information, we document it like we did here, and then we talk back to the team to come up with a plan for discharge. We're already in the mode of, okay, if there's nothing here, we need to start planning on what we're going to do next. Is there a family that can come over and stay with him, and take care of her? Can they just come and live, or do we need to find out some other means, like can they afford to pay, like, not maybe necessarily nursing home, but maybe an assisted living that would be willing to take care of this situation, or do we need to go back to our own country where maybe there's services available?
And the intern gave Raphael a lot of hope.
Yeah.
And with most of the patients with the doctors, I mean, that is the law. So that was hope that something could be done for grandma.
So what happens is when they're admitted from the ER, and the name was like, okay, they're under the team, so the intern should have called his attending. And then if he didn't know that they could get she was undocumented, then he could fix it right then and there, instead of, just, like we said, for whatever intentions of medication. Well, maybe that's not admitting them and having to sit in an emergency room for 2 or 3 days like they tend to do now, and everybody gets consulted and everybody has an opportunity to see them, because if you had more than one person evaluating that patient, I think it would have turned out quicker that this is not an acute thing. Right, yeah, they should have just called the attending right away, and it's something that does happen. They don't call the attending right away.
There's recognition that the grandmother's also an undocumented alien, and the attending now documents in medical record that there are no acute medical problems, so there is now an interprofessional team meeting. Any issues from this piece of the scenario that you could pick apart and say things might have flown differently had we done? Sure. And I think
what you're getting at is here at UTMB we have a unit that's probably better qualified with the expertise level to handle these kinds of communication and these kind of problems. Is that what I'm hearing you say? So one of the issues would be, is there a system that makes sure that this person's getting to, since they are got admitted, are they getting admitted to a place that's going to allow them to have expedite quality care with a good plan of care coming out? And that's probably what you're saying is they probably need to go to the ACE unit or acute care for the elderly unit.
And I think the one thing that we haven't talked about that's worth kind of putting into this entire picture is that the person that this is all about, the patient, cannot speak for herself. So we have a huge communication problem because she's aphasic. So when you're also looking at that part, that everything is being done on her behalf and that she personally is not communicating her needs, her wishes, her wants, her story, this sort of pot just can stir and stir and stir. So do you want to walk through sort of the discussion now, Lee, or wrap this up?
Everybody was able to show up today because I think we've got a discharge problem with Mrs. Mendoza. Everybody's seen her, right?
Yeah,
okay. Well, OT and PT caught me today because they said they really were really stressed with time and they didn't think they could come to the meeting today, but they evaluated her. And they kind of confirmed exactly what the attending and what Dr. Dominguez put down on the chart is that, you know, she's in a fetal position. It's definitely chronic. It's not acute. She's been like that for a while. She's definitely lost an enormous amount of weight. I mean, she has no adipose tissue left. Has contractures. OT doesn't think there's really anything we can do to try to improve the contractures, and PT says there's no way she's ever going to be able to be mobile again. So I told them they didn't have to come to the meeting today, that I would just kind of share their report with y'all. So let's kind of talk over before we ask the grandson to come in and figure out, you know, what are we going to do here?
Well, I have to know a little bit about what her needs would be. Since we already discussed that there's nothing that we can offer here as in the U.S. She has no funding, there's no funding available. So if we have to discharge her, you know, what are we going to be looking at? What are her needs are? I mean, as far as, does she need 24/7 care, or she's bedridden and...
So you're saying she can't go to nursing home?
She can't go to nursing home. We've already found out she's undocumented. There's no resources. The nursing homes won't take her at this point. Now, one thing we can ask him when he comes in is if the family would be willing to come stay with them, you know, stay with him, you know. But I don't, you know, I really don't know. We need to ask him.
I guess before we start going down that road, I just have to let y'all know, I told the family when I saw them in the ER, didn't know what, you know, I knew that she was not a citizen, and I gave them false hopes. I told them that we don't want to get her to a nursing home. And so those were, I had all the best intentions for her, but I didn't know that now we can't do that, so we're going to have to first tell him, because he's thinking that she's going to be able to go to a nursing home.
Well, I think one thing that I've had this happen before, one thing that we can do is sit with them and discuss what's available. Discuss, you know, we need to tell him, first of all, because he's thinking that we're going to do it. He's thinking that we have a way. Now he's going to mistrust us, so we need to explain to him in detail how the system works, how Medicare, Medicaid works, whatever, and let him know that we're not just making this up.
because right now he believes that we can do this. And so that's one way I think that we can discuss this from my discipline, is discuss to him how it actually works. And then, you know, we can all be apologetic to him about the error.
It's because I'm the one that told him and gave him the false hopes. I'll go in and I'll introduce everybody that's here. And I'll need everybody's help because obviously you have more resources and more information than I can offer. He's going to have some questions. So I guess we'll just talk to him first. I'll apologize. I'll ask him what he knows, what he's expecting, and I'll tell him where I make a mistake. And then we can ask him what questions we had or what we can actually offer.
And how they would actually, you know, how does he feel about it? Because the way it sounds like that, they just brought him here. He had no idea, so we need to figure out how he's feeling about the whole situation. You know, does he feel like he's been dumped on by his family? You know, how would he feel?
I'm sure he feels like he's been dumped on by his family. I think any of us would feel that way under the circumstance that I'm going to be relating, you know.
And because it's so important, I mean, if we even are talking about allowing her to go home to live with him again, I had an opportunity to assess her ability to eat. And the family, as it turns out, has been feeding her pureed and liquid foods using a syringe.
And I tell you, that has stirred a hornet's nest up on the ward. My nurses are just all freaked out over that.
Now, I do have to tell you, she is capable with very small volumes to swallow thick liquids, and she can handle her saliva. But shy of that, she cannot eat, chew, and swallow solid food. So she's going to need, if we are even thinking about sending her somewhere, she's going to need a lot of care just for her ADLs, just to maintain the level of nutrition she has now, which is actually very poor. But she can swallow, and I think that's important for y'all to know.
The nurse this morning reported to me that fed her that it took about an hour and 15 minutes for her to get the feeding down her. And, you know, I think I'm a little older than my other nurses, and so I've actually experienced the years in the nursing home where we commonly fed with syringes. And of course, I know it's not common now, but I believe it would probably be a good 30-minute period of time. I mean, we're not talking about a short period of time for each meal that's going to take very intense one-on-one. Do you agree with that?
Oh, I agree. And I mean, I think, you know, ideally, if we could, putting a peg in her would be fabulous, but I don't even know, I mean, medically, I don't know if you feel that would even be an option or something she would stand. And I also don't know from a hospital support standpoint, is that something we could do as a procedure on her while she's admitted? Could we even provide this feeding tube for her?
Well, you know, February 2nd, we're talking about additional care. And so right now, I don't, you know, I need to find out what, you know, what's going to happen, where she's going to get this care release. So I think when he comes in, we need to ask more questions.
I definitely don't think we need to offer a pet tube as an option, because my concern is we've offered something that we have to back out of now until we absolutely know whether that's a viable option. I really don't want to offer anything else. So let's be careful and make sure we only offer him options that we know definitively he can carry out.
Okay.
Are y'all ready?
Yeah, I think so. Let's talk to him.
I kind of got the impression you wanted to kind of lead the discussion. Okay, I think that's a good idea since you have a relationship with him from last month.
Are you feeling okay?
Yeah, I feel bad that I told him, but
Yeah, we're here. We'll work with you. Okay.
Hello. Hello. How are you?
Hey,
Doctor, good to see you. Thank you so much.
Hi, good to see you again.
Mendoza, how are you?
why don't you take a seat so we can all talk to you? We have some important news to tell you. And I'll just start out, I wanted to ask you what your thoughts were as far as what's going to be happening to your grandmother.
Well, I'm very happy and relieved that I came to this hospital and brought my abuela, because I knew I was not going to be able to care for her, and I've been trying to reach my family in Mexico because, well, it was a big problem with my parents, but they come from a different culture and they believe this is part of what I need to do and take care of, but I'm not really prepared to do this. I just started my college. Work is very busy at the port this time of the year, so it's been really hard, but I'm so glad that here at the hospital they've been taking good care of her, and even though she can't talk, she seems to be comfortable in the hospital right now.
Well, we're taking care of your grandmother the best that we can. But I actually have to tell you some news. When I saw you in the ER, and I have all the best intentions for your grandmother, but I misinformed you. And I told you that when we admitted your grandmother, I said, don't worry, I know that, she needs a lot of care. And I said the nursing home would be the best for her, and it would be possible. However, I was informed that we were not able to provide nursing home care for her because she's not a U.S. citizen. And that's part of the way our healthcare system works. And I know this is a lot of news for you because you had high hopes that she was going to be taken care of. But unfortunately, we won't be able to do that. And I have to apologize to you for giving you the wrong information and not getting your hopes up.
Okay, so she's going to stay in the hospital forever?
Well, no, maybe somebody can help me with this.
I'm Lisa Barr, the social worker, and what I want to do is kind of get an idea of when your parents came to visit with you, who's taking care of her? Were they taking care of her? Tell me how her day was.
Well, my mom and dad were basically taking care of. I have 3 uncles and 2 aunts that live close by, and they came every now and then. That's what I understand, because ever since I got here to Galveston with work and college, I haven't really kept up with what's going on. But that's my understanding. And my mom was now diagnosed with diabetes, so she's getting very tired, and so she was getting to a point where she couldn't take care of my grandmother anymore. That's what I understand.
So, Ian and Galveston, are you the only, now that your family's gone, are you the only one here? There's no other relatives here? Did you say there were others?
I have cousins 2 cousins in Chicago, but I'm the only one here.
Do you have any family that would be willing to come down and live with you? Is that, and I'm just trying to find out what options, as far as taking care of her in the home setting. Do you have any family that would be willing to live with you, or is that?
I have 2 small brothers that live with my parents, but they haven't finished school, so I wouldn't see them coming. And as I told you, my mother and father, they're getting tired of the whole situation, taking care of them.
What I did is I explored all the resources, to see if there was anything available for her, but because she's not a citizen, there's not anything that we can offer her as far as a place to live and where she can live her days and be in the U.S. So I was just wondering what your parents being, are they all in your parents are back in Mexico? Are there any other family members in Mexico that were helping them when they were in Mexico?
I think my aunts and uncles were going every now and then, but they live in the rural part, so it's not as easy to go every day and take care of her. But given that she is over 65, isn't she eligible for the government insurance?
No, in order to be eligible for insurance, let's just say Medicare, for instance, Medicare's care, like Medicare and then there's Medicaid. In order to be eligible for Medicaid, you have to have worked so many years and put into the system. So a lot of people think it's free, but we even have citizens here who don't qualify for Medicare because they didn't put into the system. So she didn't put into it, and we tried to check see if her husband ever worked here or put into the system, and there was nothing that came up. So that's why she's not eligible. And plus she's not a citizen. And so she has to be a citizen to qualify or to be in the U.S. Our state had a determination to live for 6 months and certain other diagnosis codes that would have to meet them right now at her diagnosis that she doesn't meet. So,
and my insurance, would I be able to use my insurance to cover from the port? Because I've been working there for 2 years already, so.
You would have to, and that you would have to check with your insurance, but mostly they would not cover her because she would have to be independent on the insurance. But I don't want to tell you, no, you need to check into that. But if you have the information, I'd be happy to call for you, but most of the time they will not cover her. Because here again, she's not a citizen, and that's kind of like the money. So.
How would I be able to feed her? What would be the type of care that she needs if she goes home with me, because I would need to work and go to college, so I could maybe leave things ready and try to help her and care for her, but I'm not really.
For Laura's assessment, she needs 24 hours. She needs help with feeding, bathing. We were just talking about how she's able to, swallow too, but she needs assistance with all of her activities. And if you're working, you wouldn't be able to be there 24/7 for her, which is the care she needs.
We do have private, just one thing, we do have private duty agencies that it doesn't matter if she's a citizen or not, if you can pay it. And it's usually like starts off at $17 an hour. And they can come into the home, they can provide 24-hour care, you can have shifts, you can have a live-in. Those are all the options to have her stay home with you. That
So
would be your option.
that's $17 an hour. That is a lot of money.
That's a lot of money. We have citizens here who live that can't afford it, so it's not, it's very expensive. But she would get 24-hour care, and that would be, right now, that is your option if she were to stay with you. But they actually could provide all the needs that she has, as far as, the bathing, the dressing, and the feeding, and all those things.
So, Ms. Mendoza, I think what we have is, we have a situation where we're going to have to discharge your mother back to your care. But we want to try to help you find a way to either allow you to care for her here, or maybe even try to help assist you in some way to try to get your mother back into the care in Mexico. So what I'm going to do is, let's ask Ms. Ballard to talk with you about the private pay type options, like the personal person that you would pay to come home and help take care of your mother. There are a few other situations where you can get assistance for an elderly loved one that can't take care of themselves, where they don't live in the home, that they live in other places. She can tell you how much those cost for here in the United States. And then she can also help you get information about what it would cost to transport your mother back to Mexico to your family for them to take your care. I just want you to know, we all feel very, frustrated that we can't help you. We realize, you need to work, you need to go and finish your college courses, and we realize that this is a very big stress on you right now. And it may seem as a problem that you just can't find perfect answers for. And we'll try to help you as much as we can to talk out what your options are, but ultimately you'll have to figure out what's the best option for you. So I'm going to let you and Ms. Ballard talk a little bit more. Okay? And you have any other questions for the nurses, or the speech therapist, or for the doctor, if y'all just be sure and write them down. Professional team disclosure of medical errors. One of the things is that culturally, it's always been conceptualized as being a doctor-patient conversation. And in this circumstance, the doctor was the one who made the medical error, and the doctor felt compelled to be the one to indication of the disclosure. But the issue is, it doesn't have to be the physician make the disclosure. It can be a therapist, it can be the nurse, it can be the social worker, whoever is most appropriate and has a relationship with the people that they are communicating with. So that sense of who's responsible for the communication will shift depending on the patient, the family, the circumstance, and the staff that are involved. Another thing is that if it's a team error, teams make errors, why shouldn't the errors be disclosed by a team? We talk about healthcare being a healthcare team, that not the doctor, not the nurse, not the aide, not the therapist takes care of the patient, but the healthcare team does. So any mistake that's made by any member of the healthcare team, it should be appropriate to be a interprofessional team disclosure where a group of people can discuss and disclose with the patient or family. Another is that team disclosure is complicated by power dynamics. Lots of times the conceptual that the physician's in charge for that type of higher level communication, times when the nurses feel like they're in charge,
there's always a shifting of power when you're on an interprofessional team. And sometimes that complication of that dynamic shifting of who's the group leader at that moment with that specific issue or problem kind of moves around. And the other is, there will be circumstances when team disclosure is extremely helpful. This was an example of it. This was an example of a physician who made a medical error and didn't have the content knowledge to help discuss and give the patient and family the information fully that needed to be told. She disclosed the error, but she needed the team to help provide the options to Raphael on what his options might be. There are situations where having team disclosure may be harmful. I know there are times when there has been a poor communication from a team regarding some delivery of bad news, and I've been called in and we have a big team, interprofessional, interdisciplinary team meeting with half a dozen doctors and representatives from everywhere because everyone's concerned of legal issues and this or that. And when there's too many people with too many separate personal agendas, sometimes it distracts from getting a very straightforward disclosure and systematic plan of care options out. So sometimes it can be harmful to have a team disclosure, or at least harmful to have too large of a team disclosure. The other thing is you have to understand when you have team disclosures, it's very threatening sometimes for a patient or a family member or a patient advocate to come have an audience with a group of 5, 10, 15 people. If they have been working with the healthcare team and they know the team members and they're comfortable with the team members, there's probably not a problem. But if your patient or family member or patient advocate is walking into a room of people that they have never met before and don't have a working relationship or a trust relationship with, having team disclosure may be harmful. So all those things need to be analyzed and thought about before you decide to do team disclosure on medical errors. Now, as we view the role play, I want to stop and just talk a little bit, let you talk about anything that came up that you might want to talk about. Kind of debrief it. Do you think maybe the language wasn't simplistic enough? Maybe things were a little rushed, things like that. Let's kind of debrief, and it's okay to tear apart the interprofessional team, because that's what we were up here for, was to give an example for y'all to then give feedback and think about and discuss. So what do you think? Any critique for the team? Dr. Vogelpohl?
One thing you haven't mentioned, the neighbors, if the neighbors knew, obviously, that this lady was not getting any care and was by herself, they'd probably call the Adult Protective Service and get on radio. That's one thing. The second thing, you haven't gotten the solution to this problem.
Exactly.
And that's what I'm waiting for. I gave you a solution that was the least cost.
Yeah. Well, what I'll do right quick is I'll tell you the real case. This is a real case. I embellished it a little bit, but actually this happened to me. My intern calls me from the emergency room and says, Dr. Grumbles, they admitted this lady for an altered mental status, and it's not. You know, the ER physician is wrong. This lady's been like this for years. And he said, and told me the whole story. And I said, well, just a minute, let me come down. It sounds like it shouldn't be an admission even. I said, we don't even need to get this patient up to the floor because we're just going to cause problems up on the floor if we admit. So I went down to the emergency room, and when I got down there, the resident said, I forgot to tell you, I promised him we'd put her in a nursing home, and I think I messed up, didn't I? And I was like, yeah, you messed up big time. So I went in, disclosed the medical error right then and there. We talked about it. We talked about, the fact that we couldn't put her in a nursing home. Raphael said, I was pretty sure that couldn't happen. He said, I was hoping when the young doctor said that, but, I knew better. I knew in America y'all couldn't, pay for a nursing home, and I know nursing homes are expensive, and I was hoping it, but I knew it wouldn't happen. And I said, well, Raphael, what are we going to do? I said, you know, do you have enough money to pay $2,000 or $3,000 a month to take care of your grandmother so that you can keep working? And he's like, not that kind of money. And I said, well, and I investigated what you did. I said, well, do you have friends or family in the area that can help you take care of so that you take care of her, you know, during the afternoon and evening and night and just work during the day? And he's like, no, I really don't have that either. And so then we talked about, well, what are our options to get her back to Mexico? And Raphael had called and got hold of his mother and talked to his mother, and he said, Mom, you know, I'm going to lose my job. I'm going to have to drop out of school. I can't take care of Grandma, and it costs too much to take care of her here in the U.S. I know y'all want me to do it, but I can't. And the grandmother said, bring her back home, and we will take care of Grandma. I want you to finish school because I want you to have something better than what you had here with me and Dad. And so Raphael had enough money that he was able to write a check to a private ambulance company to take his grandmother back to Mexico and deliver her home by an ambulance transport. So he stayed here in Galveston. He's still working on the docks right now. And I'm not sure whether his grandmother is still alive or not. I kind of doubt it because this happened about 4 years ago. But the grandmother went back and the parents reassumed care when they realized that their son was going to have to give up his goals and his dreams of education and a better life to take care of the grandmother. So the family stepped back up to care for him. That's what really happened in the true case. Patient was never even admitted to the hospital. We took care of everything in the emergency room, took the patient back to the home. The ambulance picked the patient up the next morning and took her back to Mexico.